The next group of drugs that we will look at are the DMARDs, the disease-modifying anti-rheumatic drugs, a term used to describe therapeutic agents which have the potential to reduce or prevent joint damage. So these are affecting the progress of the disease and not just managing symptoms. This will preserve that joint integrity and function. So the following DMARDs will be looked at briefly: hydroxychloroquine, sulfasalazine, methotrexate. Remember, it has interactions with aspirin. Gold compounds, either oral or intramuscular, azathioprine, and D-penicillamine. The properties of the DMARDs: the therapeutic goal is different from the non-steroidal anti-inflammatories. It is to intervene in the disease before the joints are damaged, whereas the non-steroidal anti-inflammatories can be used at any stage in the progress of, say, rheumatoid arthritis. DMARDs have a slow onset of action. It does take 1 to 6 months before you do see that therapeutic goal of intervening in preventing that joint damage. They do have potential severe adverse effects. They do differ between DMARDs as to their properties and their mechanisms of action, so there are slightly different toxicities as well. The selection of a DMARD for a patient with rheumatoid arthritis is made on a patient-specific basis. It takes into account all of those factors such as adverse effects, toxicity, what dosing schedule, what other concomitant diseases the person might have, therefore what other therapies that person might be on, the patient's age, and so on. Chloroquine and hydroxychloroquine were indicated for autoimmune diseases such as systemic lupus erythematosus and rheumatoid arthritis. The mechanism of action is by inhibiting lysosomal enzymes. They inhibit polymorphonuclear cells, a particular phagocyte, PMNs. They also inhibit lymphocyte responses. One of the cytokines that's very important is interleukin-1. By inhibiting this cytokine, they inhibit the ability of white blood cells to modify the numbers and the activities of other white blood cells. They inhibit the action of phospholipase A2. If you can recall, one of the first things that has to happen is arachidonic acid is made available for prostaglandin production, and so if you inhibit that phospholipase A2, you will block prostaglandin production. You will decrease the inflammatory mediators. The adverse effects of hydroxychloroquine, compared with other DMARDs, it's the least toxic. It's therefore the least costly to monitor. It's generally well tolerated by patients. It still does require some laboratory monitoring of plasma levels. Patients should have regular ophthalmological examinations. There is the possibility for a retinal toxicity. If caught early enough, it is reversible. Other adverse effects: nausea, diarrhea, abdominal cramps, and anorexia. Contraindications for the use of hydroxychloroquine: any of the hematological disorders. It might exacerbate a porphyria. It might cause myelosuppression. It can exacerbate myasthenia gravis. Contraindicated in psoriasis. And hydroxychloroquine is category D, so therefore is contraindicated in pregnant women. Sulfasalazine is available as the proprietary name Cilazapirin. Sulfasalazine can be used for a range of autoimmune or disorders which may respond to immunosuppression, such as ulcerative colitis, but yes, certainly also used in the treatment of rheumatoid arthritis. But once again, those with a milder disease, perhaps if it's not responding to non-steroidal anti-inflammatories, sulfasalazine will be tried first. The mechanism of action is once again immunosuppression via inhibition of prostaglandin synthesis. There is increased intestinal cytoprotection due to inhibition of prostaglandin degradation. So this is one that is protective of the gut. It reduces leukotriene, misspelt there, sorry, production. It does modulate the activities of PMNs, which, as you will recall, are a particular type of phagocyte. It interferes with this particular leukocyte's function. Sulfasalazine, though, can impair the absorption of folate and therefore can have effects on metabolism and maturation of red blood cells. So its contraindications will be in hematological disorders. It will be contraindicated in renal and hepatic dysfunction. If a person is sensitive to salicylates and sulfonamides, then it is contraindicated. It will interact with oral anticoagulants, methotrexate, and antacids because of reduced absorption. Sulfasalazine will lead to nausea, vomiting, and anorexia. It leads to rashes, tinnitus, dizziness, headache, oligosperma, and folate deficiency. Next, we'll look at methotrexate as a DMARD. Methotrexate, abbreviated to MTX, is a folic acid antagonist. It might be the DMARD of choice by many rheumatologists if a person has a severe disease, if they have erosions and extra-articular manifestations, it would be indicated. The mechanism of action, its close chemical similarity to folate is its main action. It competitively inhibits the enzyme dihydrofolate reductase. This prevents the reduction of folic acid to tetrahydrofolate. Methotrexate is a DMARD with the most predictable response, but has potentially the most serious adverse effects. More than 50% of patients continue the drug for longer than 3 years, though, and this is longer than is seen with many of the other DMARDs. The drug is a chemotherapeutic agent because of its antifolate inhibition. Methotrexate has a rapid onset of action, which also contrasts with other DMARDs. This is beneficial for some patients because they'll see a benefit within 3 to 4 weeks. The maximum benefit, though, is usually that long-term therapy. There are some disadvantages to methotrexate. It does need constant laboratory monitoring. This makes it a very costly drug. You do need to give a concomitant folic acid supplementation, 1 milligram per day, which will reduce the incidence of adverse effects, which you will recognize as being very similar to the effects of chemotherapy, because methotrexate is an anti-cancer drug. So the effects that are reduced by giving a folic acid supplement will be the stomatitis, nausea, diarrhea, and alopecia. The hair follicles are affected because they are rapidly dividing cells. They are inhibited by methotrexate, and so the person loses their hair. This can be prevented by giving that folic acid supplement. This supplement, it's important to note, does not reduce the efficacy in treating the rheumatoid arthritis in those doses. There is a potentially lethal interaction between methotrexate and the non-steroidal anti-inflammatories. If you stop taking the methotrexate, you can do pulse dosing with non-steroidal anti-inflammatories, but you would not give the two together. Next drug will be the gold salts. Once again, can be given orally, can also be given intramuscularly. Indications are for rheumatoid arthritis and juvenile rheumatoid arthritis. Don't let anyone tell you that rheumatoid arthritis is a disease of elderly people. It happens in young children as well. The mechanism of action of the gold salts seems to be inhibition of sulfhydryl systems in the body. Not just one enzyme system though, but a range. This suppresses phagocytic action of macrophages and leukocytes. So remember, macrophages come from monocytes, and leukocytes are those polymorphonuclear leukocytes, the PMNs, or your neutrophils particularly. Gold salts will alter the immune response. Adverse reactions to gold and the various salts include allergic skin reactions, sore irritated tongue or gums and mouth ulcers, fungal infections, contraindications, inflammatory bowel disease, diabetes, heart failure, and renal or hepatic impairment. Gold salts will interact with penicillamine, and as you hopefully will recall, it is another drug that can be used in the treatment of immune disorders, and so it is common. However, it does interact, and it can increase the risk of very serious blood dyscrasias, so monitoring is needed. Oral gold preparations have a better safety profile than the intramuscular preparations, but once again that problem of the delay before you see any disease modification. Oral formulations are less efficacious than the intramuscular dosage route. Penicillamine is also a chelating agent. It is used if a person has an exposure to mercury, lead, copper or iron, as it binds to those heavy metals, thereby helping to eliminate them from the body. The indications for giving penicillamine will be severe arthritis not responding to other therapies and juvenile chronic arthritis. The mechanism of action of penicillamine is improved lymphocyte production. They reduce levels of IgM rheumatoid factor. They reduce immune complexes in the blood and synovial fluids. Adverse reactions to penicillamine, a common theme: anorexia, diarrhea, nausea, vomiting, abdominal pain. With penicillamine, you can notice a loss of your taste senses. Penicillamine can lead to allergic reactions. It is contraindicated in renal impairment, hematological disorders, pregnancy, and Goodpasture's syndrome and myasthenia gravis. Both of these are autoimmune diseases of a type 2 type sensitivity, hypersensitivity. Goodpasture's affects the basement membrane in the glomerulus, and myasthenia gravis affects the neuromuscular junction. There are a lot of newer DMARDs, disease-modifying anti-rheumatics. The latest developments are leflunomide, etanercept, which is a bioengineered tumor necrosis factor inhibitor, infliximab, and adalimumab. The AB at the end of the name of these drugs gives you a clue that they are monoclonal antibodies. Adalimumab is made by recombinant DNA technology. And one last drug, anakinra, also one of the latest DMARDs trialled and now registered. Last of all, we'll look at gout and drug treatments for gout. The treatment goals, once again, halting an acute attack as soon as possible. Prevention of recurrent attacks of gout. Long term, we want to prevent the development of uric acid stones in the kidneys. We want to prevent complications from the development of sodium urate in the joints and also those complications in the kidneys. Treatment of gout. The management strategies that are chosen will depend upon whether it is an acute attack that is being treated or you wish to do long-term prevention or minimisation of attacks. So the drug therapies include non-steroidal anti-inflammatories. For an acute attack, high doses can be used. Colchicine and glucocorticoids, which are a steroidal anti-inflammatory. Colchicine, a different mode of action, as we'll see. Because it is uric acid that is the problem, the person may show a hyperuricemia. One of the ways of treating can be to treat that hyperuricemia using uric as uric agents. So here we're trying to encourage the excretion of the uric acid in the urine, uric as uric. One of the other drugs that might be used, allopurinol, once again a similar management strategy. So we'll look at acute attacks first. 3 treatments available for patients who might have an acute gouty arthritis with such intense pain at specific joints, such as in the big toe. First of all, you might give colchicine for an acute attack. Non-steroidal anti-inflammatories, remember that's a high dose because it's only for that acute attack. Once it has settled down, those NSAIDs will be stopped. You might give corticosteroids, either given directly into the joint, intra-articularly, or they may just be given parenterally. Colchicine is a very widely used and very ancient drug, first used for the treatment of gout in 1763, derived from a plant, Colchium autumnale. Colchicine is one of the most commonly used drugs to treat gout, despite its slow onset of action and its gastrointestinal side effects. Colchicine is most effective if started within a few hours of the inflammatory episode. So remember, it's for those acute attacks, and the earlier the better. Pain and inflammation associated with gout are dramatically reduced by the use of colchicine. And this is one of the diagnostic features of gout. If it responds dramatically to colchicine, it probably is gout and not some other inflammatory disorder. Most other inflammation do not respond to colchicine because of its different mode of action. Colchicine appears to act to inhibit leukocyte migration to the inflamed area. It will therefore subsequently inhibit their action in mediating all of that crystal-induced inflammation Originally, it is those sodium urate crystals in the joint that start the inflammatory process and lead to that chemotaxis of leukocytes, and colchicine will block that leukocyte chemotaxis. Neutrophils are unable to actually ingest the urate crystals, so it's really just an effect on the leukocytes. Because those leukocytes aren't attracted to the area, tissue-damaging enzymes are not released. Lactic acid production at that site is decreased if there are no leukocytes in the area. This will lead to an increase in the pH of the joint. At a more neutral to basic pH, deposition of urate crystals is prevented, so though it doesn't lead to the ingestion of those urate crystals, it can prevent production of more. Colchicine is given orally. The loading dose 1 milligram. It's then given at 0.5 milligram every 2 hours until there is pain relief, until that person might develop gastrointestinal side effects such as the diarrhea, nausea or vomiting, or when the patient has taken a maximum of 8 tablets. If that can be given within 12 hours of an acute attack, then it has a good response rate. 75 to 95% of patients will show improvement. The success rate is substantially reduced if there is a delay beyond those 12 hours. Most patients will experience a pain relief within 18 hours, and you will see actually subsidence of all of the inflammation around that joint, all of the redness in the skin and the swelling, certainly the pain, in 75 to 80% of patients after about 48 hours. As far as being a prophylactic to prevent future attacks of gout, it is possible with colchicine, but however, due to its adverse effects, long-term use is actually very limited. There is a select patient group for whom it is indicated, but there are very few. So patients who may need to use colchicine long-term will involve those who cannot, because of high risk with renal stones or so on, could not take a uric as uric. Or if a person has very frequent attacks of gout, then colchicine may be the therapy that needs to be tried. It does have some serious adverse effects. Colchicine is regarded, though, as relatively safe if taken in those normal doses. If a patient has renal or hepatic dysfunction, or is elderly or frail, then its safety margin is greatly reduced. The effective dose of colchicine to treat an acute attack is so very close to that toxic range where gastrointestinal side effects are produced. Because of this, 50 to 80% of patients who take oral colchicine will develop those gastrointestinal adverse effects, especially the diarrhea, and this will occur before the gout pain has subsided, so as you can imagine, this can affect compliance. Elderly patients are particularly at risk of dehydration and loss of electrolytes. It isn't contraindicated in these patients. Colchicine just requires very careful monitoring if it is used in this particular patient group. So some of the more serious side effects: bone marrow depression, renal toxicity, hepatic toxicity, neurological toxicity, teratogenicity, and alopecia. Non-steroidal anti-inflammatories can be used to treat gout. The commonest, indomethacin. They are rapidly effective in relieving pain, reducing the symptoms of inflammation, and some doctors prefer them to colchicine. Non-steroidal anti-inflammatories are best used where there has been a delay, so colchicine more efficacious the earlier you can do it. If there is that delay, a non-steroidal anti-inflammatory would be used instead. However, the earlier you can use the non-steroidal anti-inflammatory, the better to treat that attack as well. Indomethacin, the commonest used non-steroidal anti-inflammatory for gout, provides pain relief within 2 to 4 hours. Long-term prevention using gout prophylaxis would be drugs that lower serum urate concentration. As to which drug you would use for prophylaxis, you would have to weigh up many factors such as the severity of attacks, whether that person had had their first attack or many recurrent attacks. You may wish to give 2 different classes of drugs for prophylaxis. We'll talk about allopurinol very shortly, but it's a xanthine oxidase inhibitor, so operates by a completely different pathway pharmacodynamically. You may also wish to give a uricosuric drug. Probenecid is the commonest used, but I've mentioned 2 other ones there: sulfenpyrazone and benzbromarone. Allopurinol, the xanthine oxidase inhibitor, is sold as the proprietary brand Xyloprim. It is regarded as the mainstay of treating patients with recurrent gout. It reduces serum and urinary uric acid levels. It therefore is very good at producing sodium urate stones, those calculi that form in the kidneys. The mechanism of action of allopurinol is to reduce hyperuricemia. The body is inhibited in the production of uric acid from purines. The very last enzyme is xanthine oxidase in catabolizing purines. You'll recall that purines such as adenosine are part of DNA and RNA. Inhibition of uric acid synthesis is achieved by attacking 2 metabolites. The second one, alloxanthine, has a longer half-life than allopurinol. It is chiefly used for the inhibition of uric acid formation. Prophylactically, it alleviates hyperuricemia. Allopurinol may precipitate an acute attack. What may happen here is allopurinol may actually mobilize the crystals that are in the joints. To prevent this, allopurinol is not given in acute attacks. Allopurinol should be given in low doses. The dose should be gradually increased. Colchicine or non-steroidal anti-inflammatory drugs should be continued for the first 2 to 3 months of allopurinol therapy to block this effect of mobilization and pain caused because of it. Unlike the uricosurics, such as probenecid, allopurinol does not increase the renal load of uric acid and should not precipitate the formation of sodium urate crystals. It is therefore not necessary to add a urinary alkalinizer as you would have to do with a uricosuric. Allopurinol has adverse effects, and as is appearing as a pattern, gastrointestinal irritation, nausea, vomiting, abdominal pain, and perhaps diarrhea. The adverse effects are usually not severe enough to necessitate withdrawal of that allopurinol. Patients should be advised to take allopurinol with meals and with a large volume of water. Other less frequent adverse effects might include cataracts, red irritated eyes, a headache, dizziness, drowsiness, alopecia, and loose fingernails. There are rare but potentially dangerous adverse effects: bone marrow depression, hepatic toxicity, a peripheral neuritis, renal impairment, hypersensitivity reactions, and an exfoliative dermatitis. Probenecid and other urics are drugs which increase the urinary excretion of uric acid, whereas allopurinol will reduce the production of uric acid. These assist to get rid of the uric acid that is already produced. Probenecid is available under the proprietary name Procid. Salicylates, such as aspirin, actually possess a uric property if given in sufficiently high doses, at the doses for which they are used in rheumatoid arthritis and osteoarthritis. Salicylates actually have the converse effect. They promote uric acid retention. The mechanism of action of the urics is to increase the renal clearance of uric acid by inhibiting any renal tubular reabsorption of uric acid, encouraging its elimination in that filtrate and in the urine. When the therapy is started, the following processes happen. There is renal excretion of the uric acid and its sodium salt. The blood levels of urate decrease as the renal excretion increases. To restore the equilibrium between the blood urate levels and those stored in the crystals start to dissolve. They are then mobilized out of the joint. Blood urates are cleared via the kidney, and this process continues, thereby decreasing the total quantity of uric acid and urate salts. Less of these salts in the joints results in less rubbing and irritation, and therefore less inflammation. Urics are useful in the treatment of patients who are under-excreting uric acid. An acute attack may be triggered if crystals are mobilized too rapidly. So once again, as with allopurinol, low doses, titrating it upwards. Concomitant use of colchicine or non-steroidal anti-inflammatories for 2 to 3 months after you initiate a uric therapy would also be advisable. There is a danger of renal stone formation because of urinary overload, so it's important to take large volumes of fluids. Unlike allopurinol, remember, with urics, you do need to take urinary alkalinizers for the first few months of therapy to prevent that urinary overload and to reduce the risk of that renal stone formation. Urics have adverse effects including, once again, gastrointestinal tract irritation. However, the incidence of this can be reduced by taking large volumes of fluid, also very helpful for the kidney. There are rare but dangerous adverse effects: blood abnormalities, renal impairment, hepatic impairment. So just to review the treatment of gout and the drugs that will be used. Probenecid, the uric, will encourage the excretion in the urine. There is a reversible equilibrium where the crystals in the joint then are mobilized, dissolve, enter the systemic circulation. This can lead to a hyperuricemia of its own, but eventually it will be excreted in the urine, and this will lower the inflammation in the joint. So as well as increasing the excretion of the uric acid, you can prevent the production of those uric acid molecules in the first place by blocking purine catabolism. At the very last step of the pathway, xanthine oxidase converts xanthine to uric acid. The drug here, allopurinol. You can also affect the inflammatory pathway itself. Colchicine is the drug that affects the release of lysosomal enzymes, pro-inflammatory enzymes, and other mediators. Because there are less polymorphonuclear leukocytes in the area, less have chemotactically moved there, there is less phagocytosis, though they don't tend to phagocytose those crystals. The pH of the joints can be affected, leading to a condition where there is less crystalline deposition because of the lack of polymorphs and their very acid products such as lactic acid in the area.